Thank you very much. So we'll quickly go over alternative access options. You saw one of them. These are my disclosures. So it's a laundry list of every blood vessel in the body, basically, you could use for access. You heard a nice talk about the radial access. So we go into the SFA, popliteal artery and tibial-pedal access. Obviously, common causes of failure we all know. And we use ultrasound almost 100% of the time for these accesses. You don't need them necessarily in most, but we use them. And beware of the relationships. If you're coming down the adductor canal or the popliteal artery, remember the popliteal vein sometimes is superficial to that. And you don't want to go through that. Of course, be aware of the nerve in that area also. We typically, when we go distal SFA access, you just saw Andre do, we go an anteromedial approach. That usually avoids all these structures. Here's a CT scan, here's the artery, here's the vein. Sometimes these veins are duplicated on both sides. So if you're truly going popliteal, there is no way to come anteriorly from it. You have to go posterior. You really don't need to because you can access this vessel in this location. Now, if the SFA is occluded all the way down to the popliteal in this area, then we would typically approach those things through the tibials. And this is one such case, as you can see here, that now, once you get an access, this is only a catheter and a wire. This is a support catheter and an 014 wire. You still could lose flow temporarily, but this is after revascularization, and you can see that the spasm has resolved. Now, difficult to cross caps. Here's a flush occlusion, and there's a stent in there before. This was very difficult to go in an antegrade fashion, and we failed, as you can see, going on each side of this thing. The reason these are white, because this is carbon dioxide angiography in a patient with bad kidney function. We go retrograde. And in this case, there's a stent that you could go into the stent if you want. It makes it a lot easier. Or you can go below it, and we typically go into the diseased portion that is patent. And the reason is because when we come from the contralateral side, sometimes we have to put a balloon on there or stent. And here it is coming up, and you can see, now we did have a stump hump there, and so we see a little bit of an aggressive push right here to break through the cap backwards. And in this location is okay because we had a bit of a stump, but I'll show you in a case in a second where there was here we go, we get through, and then you actually do your intervention from the other side. But from time to time, and here it is, you do your intervention and basically you get through, so on and so forth. But there are sometimes cases where there's flush occlusion. This type of maneuver, be careful because you may compromise profunda. And here's a retrograde flow through the anterior tibial artery. Again, same type of thing. You come through, and here's our recanalization from the top. As you saw, this was occlusion of popliteal across the stratification. Now, this seems to be good until you go in a different projection, and you can see that we're miles apart. So you have to be sort of able to manage this in multiple projections, come in both ways, and this shows that we just basically found our way into the channel from the top. What you just saw Dr. Schmidt do is actually pretty good. The to angioplasty, the occluded lumen up here, that gives you some room to come from retrograde fashion, just like you saw right there, that the wire just passed into the lumen that has been angioplasted from the top, and this is what the results are. And here's another patient with the flush occlusion, and the approach was retrograde. Here's from the top, we couldn't do it. However, we tried, we couldn't do it. This patient had a prior bypass also, which always distorts the anatomy up here. And so we went into the stent, and the stent came back up. Again, now here's one location, as you recall, the occlusion was flush to the profunda. What you don't want to do is retrograde. When you go retrograde, is dissect across the origin of the profunda, as this wire tends to be doing. This is the no-no. So you have to go on a projection to make sure that this doesn't happen, and that you look face-to-face with the catheter from the top, and now you can get aggressive in breaking that cap. Same thing, trifurcation occlusion. These are usually the hardest when the occlusion is in the popliteal across the trifurcation. And this patient failed, although it's short segment, we miserably failed in an antegrade fashion. And so we go retrograde. This is my least favorite place to access because it's not compressible area, and you could easily get a compartment syndrome if you cannot manage a perineal access as you see here. In this case, obviously, we inflate the balloon from the other side, because once you get access, you're committed. You have to make this thing work. Otherwise, you compromise your access site. In conclusion, familiarity with alternative access sites improves technical outcome. There's quite a bit of literature out there describing these things. And as Dr. Fisher mentioned, these alternative accesses can actually improve your outcome in these CTOs from about 60-70% to better than 90%. Thank you.